Well, good afternoon, friends. I'm the other John, or John N. For the last 10 years or so, Mick Cooper and I have been researching, practicing, and investigating ways to improve psychotherapy and counseling outcomes through the systematic assessment and accommodation of client or patient preferences. As you'll see in this next slide, rather dense slide. Today we're going to be focusing on exactly that work, as well as introducing a new international website that features 2 free measures for the systematic, reliable assessment of client preferences. One for adults called the CNIP and one for youth called the U-PIC. This has been a lengthy, systematic process, and as Mick has already mentioned, truly a group endeavor in the best sense of that word. So you'll be introduced to the clinical and research foundations of working with client preferences, and of course, when not to work with client preferences. Specifically, I'll be covering some of the ethics, the research, the outcome research, and then some practice. We'll just spend 10 or 15 minutes or so showing you how to navigate and use the free website. Mick will then dive into the clinical use of the adult measure, the CNIP2, that's the Cooper-Norcross Inventory of Preferences, 2nd edition, and then the U-PIC, that's for youth. You have the opportunity to try these measures for yourself and for your clients. And then with the help of the other John, John W., we'll conclude with an entertaining questions and comments, which for Mick and I, and for any of you who have presented before, really the highlight of our time together. All right, so the next slide shows these 2 handsome devils and the schedule for the workshop. So this is now into the second point, preference work, ethics, research, and practice. After that, as I mentioned, going to the Talking Preferences website for a few minutes. Mick's going to drill down into the introduction and use of both the CNIP and the U-PIC, and then bring it home with John W. All right, we don't have any financial relationships to disclose. And as I've mentioned, both the CNIP and the U-PIC are entirely free of cost. There is a potential conflict of interest in that Mick and I do receive royalties on books we author or edit, but beyond that, we got nothing today. All right, preference works. Mick's moving me along here. All right, how about some definitions? Preferences, specific condition activities that clients want in their treatment experience. Interestingly, the research shows that we need to assess and then leverage the strong preferences. The slight preferences, it could go either way, maybe leaning this way or that. Don't waste valuable clinical time on those, friends. The research punctuates time and time again. It's the strong preferences. And by the way, when we say preferences, this is what patients desire as well as what they do not want. I'm repeatedly emphasizing this point. In my experience, it's frequently more important to know what a patient dislikes or despises than just what they may like. Next, there's multiple types of preferences. There's, of course, treatment preferences. There are preferences about the particular therapist or the practitioner. There are preferences then about in-session and between-session activities. This would be the kind of methods. Increasingly here in the States, some patients will have read, say, about dialectical behavior therapy or EMDR coming specifically requesting that. Or they want a warm or relatively neutral. Or they may be, of course, requesting specifically individual, conjoint family, couples work, group work, the type of platform, online, in person, or perhaps hybrid, and then innumerable considerations regarding the length of sessions, the frequency of sessions, and so forth. As we've also said, we can make a simple distinction between what occurs within session, which versus what happens between the sessions. Hence, between treatment preferences and within treatment preferences. And there are quite discernible stages of preference work. We elucidate these as eliciting preferences. We can do so by having general discussion, and in fact, we have a slide on certain ways that you may invite your clients to have this dialogue. Then we have specific assessments, then a discussion about whether you're able to accommodate those and when you're not able to accommodate those. And then at some point you are literally matching those preferences and trying to keep those in mind throughout the work. Of course, preferences do change over time. Mick and I take seriously the ethical mandates for collaboration. Each ethics code expresses this a little different, but the research examining the principles across literally thousands of mental health ethics codes show there's considerable overlap. We value preference work in part because it highlights and privileges the client's voice, hoping to get through the paternalism that historically characterized much of early psychotherapy. In the best situations, this is a shared decision making, SDM as it's frequently called, and that is situated clearly between a client-led session or treatment, and on the other time, a therapist-led. This in no way, preference work, in no way devalues the clinician's expertise, knowledge of the research, and the like. Rather, it invokes and invites the patient for a truly shared collaborative endeavor. And anyone who knows the research on the therapeutic alliance and relationship knows that collaboration solidifies the therapeutic alliance and absolutely predicts outcome. Next, Mick. In other words, we are highlighting the uniqueness of the individual as a unique entity unlike any other person. Distinctive, irreplaceable, and inexchangeable. Hence, we should be anticipating and honoring those unique preferences. So virtually all codes, I cannot personally attest that it's all codes, as I haven't read thousands, but as a co-author of a leading textbook over here on codes for psychologists, I could tell you virtually all list patient preferences as one of the decision makers. My professional code of ethics, the American Psychological Code of Ethics, for instance, emphasizes shared decision making with patients in several aspirational principles. That includes patient autonomy, informed consent, and then clinician competence. In fact, a close reading of the APA ethics mandates that psychologists collaborate with their clients to make informed voluntary decisions about treatment, not only at the onset, but as patients acquire competence and experience in therapy and then over time. Mick has provided this slide. Ethics work on preferences capitalizes on being openness to the other, in which we bracket our assumptions, biases, expectations, and demands. To open out to the face of others in all of our respective uniqueness. So, what about the research evidence? It is considerable. And a fun fact here, I had a reason to look up my doctoral dissertation, now 42 years ago. And to my surprise, I had forgotten that the topic was psychologist change versus patient change. So for 40 some years, I could say we've been investigating this. But we have lots of slides with this. If you simply ask clients, I would like my therapist to, on a 7-point scale, would you like your therapist primarily to help me reflect on my childhood or my adulthood? You can see they use all those points, right? This is similarly, give me homework or not give me homework. Now, what's interesting here, therapists themselves are not huge fans of homeworks for themselves in the patient perspective. But most of our clients would prefer some between session work, assignments, or recommendations. But you'll see they are expressing diverse perspectives that cover the entire range of the scales. There are now at least 7 peer-reviewed published reviews of the effects of preference assessment and accommodation in psychotherapy. What I believe is still one of the best is Joshua Swift, including our own Mick Cooper. Yes, in a book that Bruce Wampald and I edited. They found and analyzed 51 studies, including over 16,000 therapy patients, comparing the therapy outcomes of clients matched to their strong preferences versus non-matched to preferences. In other words, what happens when you match preferences? Well, patients receiving their preferences were almost half as likely to drop out of therapy prematurely. That's an odds ratio of 1.79. So by systematically assessing and, when appropriate, matching those strong preferences, you are reducing dropout by almost half. That's a powerful effect indeed. If you simply look at what's the improvement in outcomes by that accommodation of preferences, it's smaller. It's about a D of 0.28. So still significant, still something we would like. So you are both literally improving the effects of therapy, however you measure them, as well as reducing dropouts. The next couple slides provide some additional details on these other review papers, including this qualitative meta-analysis. This particular study included psychotherapy, medical, and other psychosocial interventions. Clients generally have quite positive reception to having these choices. Certain themes emerge, such as the opportunity to build trusting relationships. They certainly value being construed as active participants. And if you've ever had a personalized experience, even if it's how they make your tea or coffee, that's a heady experience where you are treated as an important person. So if we put together all these meta-analytic findings from 7 overlapping studies, systematically assessing and accommodating strong preferences does systematically lead to small improvements, with the strongest evidence to date for depression and anxiety. Patients are reliably satisfied with this, feeling involved, shared decision-making, exercising choice. As I said earlier, you reduce dropout by almost half. There's less quantitative evidence specifically about enhancing the alliance, but there are indeed supportive evidence. And I should underscore, virtually all of this research evidence is based on adults. there's no yet strong evidence for this with young people, but by introducing the U-PIC measure, I suspect that will be coming in due course. All right, so I hope I didn't bore you with the data, death by data. Let's now jump into the practice considerations, including evidence-based practice. This is the classic tripartite categorization of decision-making in terms of harnessing the best available research with your clinical expertise, and yes, adding patient characteristics, culture, and notably for today's session, preferences. Literally at that intersection is where we have evidence-based practice. So why, whoa, that was quick. So what are the probable mechanisms of action? You'll notice here, we're hedging our bets a little by calling them probable mechanisms of action. First, because there's several hypothesized mechanisms. And second, we don't have direct research support on all of these. Well, the first one is simply matching effects. Many, not all, but most clients have a sense what is most likely to help them. And they simply do better when they get what they want, especially when they possess what's known in the literature as domain familiarity. We would know it. They have some experience in therapy or at least healthcare. They know, for example, that maybe individual works better than group, or group proves superior, or they work better when someone is not confrontive. So matching probably works, as does having choice. Decades of research in all of psychology demonstrate time and time again, people love choice. It feels empowering, it feels personalizing. This is especially true when patients have a higher desire for control. That is, if they're a little reactant or resistant, then choice is even more important. I may also add that large body of research on choices underscores time and time again that the number of choices cannot be overwhelming. Hence, you'll see on the two measures we've constructed, we restrained our impulse to have 12 or 13 dimensions. We have limited it to 5 or 6 important dimensions. Yes, and there is a section for other possibles, but we know too many choices proves bewildering and unhelpful. Another mechanism of action that we've mentioned already is simply enhancing the effects of the therapeutic alliance. Doing the preference work, the discussion, and the like establishes, solidifies the therapeutic alliance. Right? It's part of the task. You're solidifying goal consensus and certainly helping create that warm bond. Less research for this, but we do believe preference work probably improves the patient's insight or awareness. It helps clients identify their deeper wants and needs, and importantly, what they do not want from the therapist. Because remember, in preferences, it's both what a patient desires and despises. And Mick has emphasized this point, which in truth, I probably neglected early on. Doing this work in session, in person, is sort of an in vivo skill development, particularly for more reticent, passive, dependent patient. Dialoguing and negotiating with an important other therapist can help clients develop that assertiveness skills and related communication skills. As a patient said not too long ago to me, I've been in therapy off and on for 15 years. And having this discussion in the first session was a turning point. I know the other therapist liked me and tried to give me what helped, but this was the first time I was explicitly asked what I wanted. So that sort of embodied the alliance and but also the skill development that he had not had, if you will, a corrective experience with the counselor. Now, if I'm at all empathically attuned, because we have done this presentation in different variations a few times, I suspect you're sitting there and saying, that sounds very nice, American Johnny. But whoa. Let's work through some of the concerns. First, John, clients don't always know what they want. Exactly so. So when we begin assessing these, you'll want to empathically anticipate that and say, you may or may not know. So we normalize that. But particularly experienced clients absolutely know. When I ask people, you've been in therapy several times, what have you learned what you don't want? Oh, out comes a stream of expletives. They certainly do know when respectfully asked. And if they don't know, we normalize that and return to that. Secondly, you may be saying, but what clients want is often the last thing they need. You're actually deepening or strengthening their neurosis and psychopathology. Well, when we get to how we say, I'm not sure that would be in your best interest, this may be the case. So we've anticipated that, and as ongoing clinicians, Mick and I have certainly experienced that. Next, clients' preferences change. Indeed, they do. And as a clinician, you will occasionally reappraise their preferences, ask them if they're still working. Sometimes they'll change in one direction or the other, so they're not static, but that's a given. It's like saying clients' goals change. Yes, that's absolutely true. And you'll stay attuned to that. The one that Mick and I discuss quite a bit is the clinician who will complain, well, come on here, Mick and John, I can't be all things to all clients. Am I not supposed to be authentic and congruent? Yes, you're supposed to be authentically flexible. You're supposed to be genuinely helpful. And that means helping in different ways. That's true congruence. But yes, if you cannot accommodate all clients, then you're going to have that important conversation, and when needed, simply refer. This is no different if a patient asks for medication and you don't prescribe, or they want group therapy and you don't offer that, or they want a particular technique. So you'll accommodate when you can and refer like in any other case. Don't we do this already? Oh, this is an easy one. Hell no. If we ask, do we think we do this already? Oh, hell yes. But I have watched and commissioned literally hundreds of psychotherapy videotapes by supervisees, the APA Psychotherapy Videotape Series, which now features more than 400 tapes. Only 4 therapists of those 400 did this explicitly. We think we do it, but we do not routinely do it. Sorry to disabuse you of your favorite notion here, friends. I'll rebuild our alliance, don't worry. Next, I already know my patient's or client's preferences. I know it reliably. It's called intuition. Let's just move on before I hurt our alliance further. So, as I mentioned, the fun fact that we've been doing these studies in different varieties. If we simply generalize from our experience as therapists, would we be accurate? Sometimes yes, sometimes no. So take the simple question, in this therapy, should we focus on specific goals or not focus on specific goals? In black, you can see the 7-point responses of mental health professionals. In general, again, great variety or diversity in what they want, but they're a little more toward the left, as you can see. By contrast, 2 samples of laypersons are a little more to the right. So if we intuit or assume that what we want as humans would characterize our patients, we will frequently be inaccurate. Say it again, there's evidence-based practice. Oh, here's my favorite slide. Who said it? First person to get this correct gets a free book from Mick Cooper. He didn't know I was going to say that. He's got a great edition summarizing psychotherapy research. Actually, I'd send it to you, but it's then international. It's a pain. Who said it? It's a client who knows what hurts, what directions to go, what problems are crucial, what experiences are deeply buried. It began to occur to me that unless I had a need to demonstrate my own cleverness in learning, I would do better to rely upon the client for the direction of the process. I'm sorry, Lawrence. Yvonne beat you. Mick, Yvonne gets a copy of the book. It was indeed Carl Rogers.
I was going to say it myself, so I would get to send myself a book.
Not here. Oh, it's Ivana. Ivana, if you don't get it soon, you have Mick Cooper's number now. And honestly, I would send you one. It's just international mail, such a mess. All right, let's talk about what to assess here. We mentioned earlier, there's, back one,
Sorry.
Treatment preferences, therapist preferences, activity preferences. Okay? When are you going to assess? Some people actually prefer this to do pre-contact. One of my colleagues here who sends a fairly detailed life history questionnaire has simply added the CNIP2 to the life history questionnaire so that he has it, patients can reflect and bring it in. Honestly, I've never tried that. I prefer the in-person, but that's actually a fairly inspired idea. After we establish the treatment goals, most of us do it during our intake or assessment session. You then may do it at scheduled reviews. So if you say every 3 to 5 sessions, you take a moment to conduct client feedback, or, ooh, I hate this term, routine outcome measurement. It's not measurement, it's feedback. You could also ask about how you're doing in accommodating and how they're responding to your preference work. Final sessions is not a bad idea as a wrap up and an overview, specifically if they move forward in therapy. And there's some markers, if you will, in ongoing therapy sessions that we suggest you might just take a moment and ask. For example, therapy is not progressing well. You feel stuck or not making progress. When you experience a rupture in the alliance. When you feel a little frustrated or confused and don't know quite how to proceed. And as the ending or termination approaches. We all think they're wonderful times to just ask about preference. It may be a 30-second check-in, but sometimes it's a critical concern. It can easily go 30 minutes. I promised we've gathered some opening wording for how to discuss invitations. And on the website, by the way, we have several practice sessions of this, so please do look at those. Do you have any thoughts on how we might go about reaching these goals? Because that would be a transition between establishing treatment goals and then preferences. What do you think might prove useful here? And they may say, and remember, equally important, what do you dislike? I actually use the word dislike or despise because I want a little more affect. Anything you'd really like or not like? What have you found helpful or unhelpful in previous therapy? Or those of you who do some brief in-session exercises, I invite clients to close their eyes, breathe deeply in and out a few times, and just imagine in your mind's eyes what you would really like happening in here. What would I do? What would really annoy you if I did? For people who are more reflective, they appreciate that invitation. Of course, all this still follows and aligns with principles of good practice. We're not asking anyone to extend beyond their scope of practice. We embed that preference work in a good therapeutic alliance. It's the dialogue that counts. It's just not the destination of getting them, but the journey in dialogue and establishing. You ask from a confident perspective. Occasionally, our youngins, our trainees, ask in a way that the patients misinterpret, and we've even had patients say, well, don't you kind of know what you're doing? So I'll even say at times, I've been conducting therapy for 40 years. If you haven't, you can borrow that. So I have lots of experience, and if I learn one thing, it's to learn and personalize therapy to you. That's another way of introducing that discussion. Remember, you capitalize on strong preferences. Top and tail, what we would say pre and post, you combine preferences with those evaluations or client feedback or routine outcome. And of course, it is an ongoing process. We're open to changes in patient preferences, just like their goals. As I mentioned, those two very quickly are on the website or on YouTube, and you have the slides. They each take about 5 or 10 minutes. Mick and I just demonstrating different ways of assessing preferences, and equally importantly, how not to do it. So I'm going to end my 40 minutes, friends, with now that you've initiated the dialogue about preferences, you will learn to systematically assess them. Well, what are your primary choices? Clinical expertise and research evidence converge on what we call the 4 A's. So we'll go through these briefly now and then have some slides to expand. The first A is you could simply adopt the patient's strong preferences. Remember, not too many. Too many choices can be overwhelming and bewildering. So when a patient says, I like people to give me active things to do and maybe something between sessions, you'll say, well, you'll probably reflect, make sure you understand, and say, I'm very comfortable doing that. You would be adopting. If you can't entirely adopt because your experience and the research maybe not support it, you could then adapt that strong preference. Let's say someone says, well, I'd like to be seen 2 or 3 times a week. And you say, well, my schedule would not accommodate that 3 times a week. Could we go once 1 week and maybe twice, and then I could try to work you in? So you take the gist, the sense of it, indicate your willingness to have shared decision making, and do the best you can and see if that works. The third is an alternative. You respectfully discuss why accommodation would impede progress and outcome. For example, in one of those YouTube slides on the website, a patient says they're big huggers. I say I understand about some people wanting hugs, but particularly in the States, an occasional hug is certainly within ethical boundaries, but we need to be concerned about miscommunications. I talked to the patient. She immediately said, yes, I understand, My physician is not a hugger at all. And I said, could I give you verbal hugs so you feel supported, and on occasion, perhaps a hug, and we could talk about that? And she says, that would work fine, and I do understand how it can be misconstrued. And finally, if they just want something you cannot provide for reasons of ethics, practice, research, then you're simply referring them to another service or professional. Let's briefly expand on these. Here's the accommodating. If it's within your expertise and you can do it, please do it. You've already seen the research attested benefits of adopting. Here's that adapt. You take the gist, but there's some mismatch. You're not quite all there. And we just hash it out. And Mick's going through those because I've always mentioned that they're on the website. So there's some brief demonstration videos. Mick and I found them hilarious, mostly because we're embarrassing ourselves. Maybe they're not as funny for you. The alternative here. When you're unable or unwilling to adapt or adopt, you just propose an alternative. Importantly, you explain your reasoning. You empathize with their possible or probable disappointment, educate, and at this point, it's a negotiation, whether you believe with their disappointment in not getting quite what they want, whether that will happen. By the way, my experience, when you say, I know this is probably disappointing, and I completely understand if this is not satisfactory, I'm guessing 90, maybe even 95% of patients say that will work. And remember, because they had not usually had anyone even ask this, so they're already feeling that they have choice and shared decision making, and like, wow, this person really does want a personalized therapy to me. So when you just say, I can't quite get there with you, I know that's disappointing, they really, like 90% of the time, get there. Mick, would you unmute? What's your percentage on the alternatives? I don't want to overclaim.
I think that's right. If you have a dialogue about it, then most clients are, in my experience, happy to, as you say, to consider alternatives. And I really like what you're saying, John, about it's a kind of sign of care, the willingness to have that dialogue in itself.
Thank you. So I know we're being recorded. Let me retract the 90%. Let's just say the vast majority, in my experience, absolutely. And usually at this point, they begin apologizing to me that maybe they asked for too much. And I'm like, whoa, I've never had that happen before. Next. So that was just again offering the alternative preference. Next, Mick. So the another is when simply cannot accommodate. Patients likely to be a little disappointed, but perhaps their strong preference is not consistent with the research evidence, not with your ethics, not with practice, not within your competence. Hence, we just simply consider another referral. And good practice in making those, wait. If you'll just go back to that one, Mick. Be clear what you can and cannot offer. You accept your limitations. We refer in a collaborative way. And sadly, we must know that some patients, particularly interpersonally sensitive patients, may be experiencing referral as a rejection or something wrong with them. We emphasize that this is simply a scope of practice due to their limitations. I frequently use the analogy of, for example, you happen to get to a surgeon when perhaps really you meant to get to the urologist or the GYN. It's just not what they do. It has nothing to do with you. You enjoyed meeting them. Whenever possible, we have concrete suggestions and specific sources. And if the patient's willing, you get a quick written permission. You can communicate with the future clinician and perhaps forward the treatment goals and whatever preferences and life history you've gleaned. So you're still doing good preference work, even in onward referral. And with that, I now turn it over to Charlotte and other members of the team to introduce you to the Talking Preference website.
Thanks, John. That's fantastic and such a good introduction to the work and the meaning of it. So we're going to move on now. Charlotte, who was so instrumental in helping us develop the Talking Preferences website, is going to give you a little tour. And we're also delighted that Kay, and I think maybe Brad, definitely Kay, who designed the site, is here with us, and maybe they will say a few words. So Charlotte, over to you if that's okay. And if you want to screen share from your end and just take us around the site.
Okay, thank you. Hello, everyone. I'm Charlotte. I'm a trainee counselling psychologist at Roehampton, and I'm actually testing the U-PIC, so that's the young person's version, live in therapy at the moment. So it's absolutely fascinating. I'm just going to quickly hit the share button. I'm not au fait with Zoom. I do apologise. 1 second. Sorry, I do apologise.
John, I can do it my end, Charlotte, if you want.
Can you see?
I think it's just on its way. Hopefully it's coming through soon.
The bar is just in the way.
There you go.
Can you see?
Got
Okay,
it.
thank you.
Great.
Right, great. Okay, so yes, welcome to our website, talkingpreferences.org. And it actually took a while to get to Talking Preferences. We thought of lots of other different titles, including Counselling and Psychotherapy Fit, and thinking, is this too athletic, for example? But we've come across Talking Preferences, and we're delighted. And it was a complex brief, actually. We had to have a website that was for both adults and for young people. It had the complexity of building the interactive forms into the website. And obviously we recognise that it's not easy and it's not particularly pleasant for people to come to therapy, but we wanted something which had sort of vibrancy and a bit of fun and playfulness to it. So we went to We Are Jungle, and that is Brad and Kay. I'm just going to whiz down here a second. That is the byline there. So We Are Jungle are Brad and Kay, and are they said Kay's here. I'm not sure if Brad is here. And I'll come back to you at the end, Brad and Kay. But I just want to quickly just quote something from the We Are Jungle website, and that is, Kay runs the schedule like it's the Navy, and she definitely did. And I think this was something that we definitely empirically validated. And then I thought, why not the Army? But you are based in Portsmouth, aren't you? So I think that was probably a nod to geography there. So I just want to bring up the Talking Preferences logo. This was this is about a week old, actually, and was organised by Sally, which will be on the site perhaps in time to come. Very exciting. And you can see it's fingerprints, which is inherently human. It's the Tunus, which is the therapeutic alliance between the client and the therapist. And the multicolour is a nod just to the diversity and all that we are. So this tabulation up here, the buttons in the website all relay back to these 5 areas. So you're not going to get lost. It's clearly signposted. And if I can go into the menu bar, you've got this wonderful pink massive smartie, which interacts, I think, so beautifully with these different areas. But coming back. So we have the landing page, and if we scroll down, we've got some quick link buttons to these 2 areas. We've got the mission statement, which John has just been speaking about a lot. And then we've got the adult section. Again, you've got these quick links coming back to the adult questionnaire section. and then the U-PIC, the young person's therapy preference measure section, a quick 3-step guide for clients of how it works. So you're going to answer the questions. The questions are in sets, and each set is a dimension. So I'll show you what that looks like in a minute. You answer the questions, you get a concise summary, and I think, Mick, you're going to be going through, I think, after me, and then you use it to support your results in your therapy. And I'm actually working with young people at the moment, and they're trialing it, as I said, in their therapy. And 2 young people in particular, they've had therapy for a while. They know their therapist really well, but still the questions that they have to answer in the U-PIC are really raising and breaking apart the therapeutic processes. So they really have to think. So what I'm saying is, it's not just for those initial start-ups of therapy, and of course they're great for assessment, but even people, or young people especially, who are aware, or they think they know about therapy, are still really having sort of in-depth conversations with their therapist about the results. So just starting from the beginning, we've got Mick and John. Don't know who that is. We've got Andrew. I don't know if Andrew's here. Andrew was incredibly good at finding acronyms for us, and also really useful on the U-PIC dimension. We have Eva and Emma. I'm not sure if everyone's done introductions, Mick. I unfortunately missed the first part. No, okay. We've got Eva and Emma, who are the young people project coordinators who helped us with from the McPin Foundation. And then we have what I say are the measure maestros. We have Gina, Thomas, and Strong, who have so much experience in putting these measures together. So we scroll down, we have the view resources button, which comes up to this area here. This is amazing. I don't know how they've programmed this to never the mouse and the first arrow will meet. Then we have some frequently asked questions. So these are for clients. What if I don't know what I want in therapy, for example? Do I have to pay? No, you don't. I just want to come down to this section here. And John, you mentioned this in your talk. And I think as a therapist, I feel exactly the same. What if I can't provide the young person, for example, with what they want? But it is the basis for a dialogue. And how I look at it as well is, well, if you really want that preference and I can't offer it to you, what is it about that preference that enables you to do or talk or feel comfortable? And then I can move across to the other side. Well, what is it that you don't like about this? So there's loads of different ways that you can open up this dialogue and this relationship, which I think is really interesting. So 2 quick link buttons there again, and then we're going to go into the adult section. So a brief introduction, just letting you know what the CNIP2 does, how you can use it to explore your therapy preferences, and you can press the button there. Some instructions, some scoring instructions, but you don't have to. So this is all built in. And so, for example, this is the first of the scales or the dimensions or the sets. I mentioned there's 8 sets you can see for the adult CNIP2. And here are your responses. So I can explore my past experiences. I can't quite see that, I'm afraid, on my screen. So let me move you. I can explore my current experiences. And then these are the responses I can give: strong preference, moderate preference, slight, no or equal, and then it goes to the other side. So as a psychodynamic practitioner, I can think, yeah, okay, I really want to explore my past experiences rather than my current, and I want to concentrate on my early years, for example. I want to look at both past and present events, and then I will click next, and it will go on to the next scale, and so on and so forth. So we move down the landing page. You've got the adult resources, which takes you back through to this area here, and then into the young person's questionnaire section, which of course I'm a bit biased towards. Simpler language, age-appropriate instructions. It's a smaller form. It's different scoring. So, for example, a lot, a little, don't mind, or want. And speaking to the young people at the moment, they're really engaging with the a lot versus a little. They see a meaningful sort of differentiation between these two, rather than the difference between 2 and 1, for example, or 3 and 4. And the want both is very popular. And I think this is really good for young people because they don't know what they want in therapy a lot. They don't want to miss out. They're thinking, okay, if I choose this, what am I going to lose there? So that sort of loss aversion, I suppose, a protection against. Some resources again, which lead back up to this area here, and then our wonderful young people from the McPin Foundation. Ellie is here, I believe, and Hemlata, and then we'll go into the resources. So this is quite a chunky section, but it is defined, and the most important thing for therapists, for me, I think anyway, is that you can download the CNIP 2 as a PDF form. So if you don't want to use screen time, for example, or you want to give your clients a hard copy, it's there. This is an HTML whizzes and bangs, amazing sort of interactive HTML version by Brett Raymond Barker. I don't know if he's here, but that's really fun to play with. He is. And then we've got the guidelines, obviously absolutely imperative. They tell you about the scoring. They let you know maybe how to introduce the measure into your sessions. And then there's a quick link. Same with the young person's version. So we've got the downloadable U-PIC there, which I think is going to be shown to you later. And then the guidelines. I categorize these as sort of the siblings, I suppose, of the CNIP. They're all adult based. You've got the retrospective here, which is how was it for you to choose your preferences? How did it go? I'm going to point out this one, which is if you're a therapist, perhaps you have a go yourself. What are your preferred ways of working? This is interesting. So I'm going to use this in my supervision. And I can say, for example, to my supervisor, I want you to give me more theoretical input. And she can say no, for example. That's not how it works, Charlotte. And then we've got the translation guidelines here. So if you are speaking in a different language, I think this is an amazing opportunity to work with the university and validate it and translate it and rescore it into a different measure in your own language. I think is amazing. These are the videos that John commented on. So the how to and the how not to's. We've got the presentation slides, which will be useful if you're a lecturer or if you want to introduce perhaps the measure into your service and discuss it with your therapists. We have the publications which test and validate the measures as the years have gone by. We've got the book. And I think the about, I think, is what you've heard, really. It's the beliefs, it's the philosophy behind what preferences are, what is offered, and how you can use it. And then lastly, we've got the contact form, which you can write a really complex question or complicated question, submit it, and it goes straight through, I think, to Mick Cooper, who will answer it in 5 working days. And that's it. And Kelly, are you there? Is it possible to speak to you?
Hi.
Or Brad?
Hi.
Hi. How are you? Yeah, so how was it? Are you pleased it's over? I don't know if you want to just say what the difficult bits were. Hello.
Oh, I've loved working with you guys. Obviously, listening to John, it was so interesting because obviously when you're building or creating it, you're doing it from a creative perspective and you're just putting the content in and you don't really take in what you're putting in. So it was really nice to hear the presentation and think, oh yeah, like I remember seeing that part and that makes sense now for that bit. So yeah, it was really interesting to put all the parts together. The resources was a fun page. But yeah, it was an amazing project. I think it's turned out really nice. I think it's nice for adults and children. It's exactly what you asked in the brief originally, which was you wanted it to not seem too serious, but also it is obviously a serious subject and you don't want it to seem like, too silly or too. So I think the balance is really well done. It's got nice diversity within the imagery and yeah, I think it's nice. Obviously I'm biased.
You did all the work. Thank you very much. I'll hand over to you, Mick.
Yeah, thanks so much, Kay and Brad, for all the work you did on the site. It looks fantastic. And just one thing I wanted to add about this site is about the one of the things we really wanted people to be able to do on it, if I just share it myself, is to actually complete the measures. So I'll talk through the measures a bit more in a minute, but just to show you that if we go to the young person's measure, for instance, if we click through, I'll just do this very quickly and then there'll be a bit of time if you want to try it out on different responses. Then the idea is that clients can be sent here or people might just come here to get a better sense of what they want from therapy. And then what you see is that it gives you John was talking earlier about strong preferences. And what the system does, which Brad's out brilliantly, is that it then tells you essentially, as I've indicated, that I prefer creative activities, that I want therapists to lead on that dimension, emotional intensity, therapy's challenge. And then if I ask to print off, and I can do that as a PDF, then it will give me all the scores on each of the items, and then the total indicating what the overall preference is on that scale. And as I'll talk about, this is obviously, it's not a kind of recipe and saying to the therapist, you have to do these things. But the idea is that it's the beginnings of a dialogue, and a way of empowering young people or adults who are clients to be able to have a conversation with their therapist really about what it is that they might want, or as John was saying, not want in the therapy. So John W, Wee John, as you're now known. So is Wee John an American Johnny? That's good. I like that.
Here we
Um,
are. Yes.
do we want to take a break? Should we do a bit more, a 5 minute break? I think
I think a 5 minute break's a good idea. Yeah, give us a little pause. 5 minutes to get the kettle on, a little screen
so.
break, and
Yeah,
yeah.
5 minutes to get the kettle on, and then what I'll do is I will talk through the measures, and we'll have Ellie's going to come along and also talk about the young person measure, and then we'll have time for Q&A and maybe introducing the rest of the team. I wanted to talk now about our the measures and the CNIP, and can you see that okay? Oh,
Yeah, looks great, Mick. Thank you.
yeah, and so the so this is so we've been working, as John was saying, we've been really working hard to we developed a inventory of preference. John and I published in I think 2015-16, and it worked pretty well, and it was been translated into lots of different languages. But some of the reliability of the scales wasn't great. There were other dimensions that we wanted to measure. And colleagues of ours like Thomas, who's here, and Jean Schrade, Strong, were involved in kind of analysing data from other countries, and it was doing okay, but it wasn't brilliant, and particularly for kind of research purposes. So we went away and we really spent the last 3-4 years. It's been a long process, and we've had some really good financial support from John's University to develop a revised version of the measure for adults, which is the Inventory of Preferences 2. And we've had colleagues like Brett have worked really hard to get these stats on it right and to find the right items. The idea of it is basically that we want clients to feel that they can say something about their preferences on different dimensions. And the way that we set up the dimensions, I'll talk a bit more with a young person's measure, but essentially what we wanted to find is dimensions where therapists were quite happy to vary their practice and would be interested in hearing what clients wanted. So, something like, for instance, being empathic or not being empathic, that's not a dimension here because most of us as therapists want to be empathic or caring, not caring. We didn't want to, we're not really going to vary much on that. But then on other things, like, for instance, for me as a therapist, if a client wants to talk about the past, great, I'll really work with that with them. And if they really want to talk about the present or the future, that's great. I don't have a strong feeling because I'm happy to do both. And that's where hearing like the client's views and their thoughts about what they might want becomes more important. So the idea is that we've got these different scales and we've got several items per scale. We try to keep it as brief as possible, but obviously for kind of research reliability, we needed to have a few items per scale at least. And we tried to then work out what these dimensions were through quite a long process, and I'll talk that more about with the young person's one. So the dimensions we've got now, we've got these 7 dimensions, and there's probably likely to be many more dimensions. For instance, working on the therapy relationship might be one, or doing certain techniques might be another. But the kind of the generic ones is one whether does the client want to talk more about the past or the present? Do they want the therapist more to lead, or do they want the therapist not to be in such a kind of leading role, and perhaps as the client they want to lead that process? And I know in my own work I've worked with clients who really want me to take a lead and direct the process and be kind of more proactive, and others that basically want me to, give them the space to do the work. And again, that's something that I'm really happy to do both. That's where I want to know what client wants. Warm support and professional reserve. Some clients just want something that's a little bit less kind of personal, whereas other clients do want something kind of warm and friendly. But I know that some people just don't actually find that particularly helpful and find that a bit kind of cloying and a bit too much. Something about homework, between session work. Again, if I'm working with a client and they want things to do in between sessions, great. If they don't want things to do between sessions, that's great as well. All of this is kind of based on these pluralistic principles in a way that different clients need different things at different points in time, and they're going to want things, and it's useful to hear what they want. Doesn't mean, as John was saying, I think really importantly, it doesn't mean, the therapist says, supposing you're working with a client who comes in and they say that their problem is that they're always doing what people tell them to do, and they feel that they're not assertive and they feel nobody's listening to them. And then on these measures, they say, well, what I really want is the therapist to lead. I mean, as a clinician, you might be thinking, well, is that really going to be helpful for you if your problem is around kind of not, feeling very led by people in the first place? And as John was saying, it's the dialogue, and we bring in our expertise, but we also listen to clients. And I think, in terms of those kind of cautions, there's a risk of thinking that because clients don't always know what they want, therefore it's not worth listening to them at all. And that dialogic position is one of saying clients aren't always right, they don't always know what they want, sometimes they won't have any opinions at all, but let's have some space where we can enter into a dialogue and bring in our expertise and their expertise to work out the best thing. So the next one's about kind of insight or action, and that is one particularly our colleague Thomas, who's here, kind of emphasised that we should bring in that some clients want to focus on awareness and more about self-understanding, and some want to focus more on what they actually do and how they change things. Big dimension, and actually and this surprised me, but the most strongest dimension, and again, by that I mean the kind of one where there's the most marked variations, is around how much clients want to do emotional work. So some clients really want to work on their feelings and bring the emotions into the room and focus on emotions, and others are much more cautious about that. And again, I think being aware of what clients want there is really important. And then there's another one, a final one for the adult one, is around challenge. When we went into this, I mean, one of the great things about the statistical analyses is that it kind of pulls out these dimensions that you might not imagine. So for me, for instance, I always assumed that the one about challenge and the one about directivity, the lead one, would be basically the same, that clients who wanted the therapist to lead would also want challenge. But actually, what we found is that they're different dimensions, and that some clients want a therapist to lead but not actually be that challenging, and some want the therapist to be challenging and not lead. So it's a clinical tool. It's also very useful for research. I mean, we found out some things. For instance, we found out that female clients are more likely to want warm support. Male clients are more likely to want a therapist challenge. Interestingly, the thing that I found most interesting was that in terms of predicting which clients would do best in therapy, and this is using our earlier version where the dimensions were slightly different, but in terms of predicting who would do best in therapy, it was things like whether the therapist leads or not, their preference there didn't matter, or the warm support, or focus on the past, or emotions. I thought clients who wanted to work on their emotions would do best, but actually that wasn't the case. The one thing that predicted it was that the clients who wanted warm support had the poorest outcomes, and the clients who wanted the most challenge had the best outcomes, which I think is really interesting and perhaps relates. John's done a lot of work about stages of change, and it might be something related to clients who want challenge are further along in terms of stages of change or more open to change. And as somebody who practices in a very relational way, that was quite a challenging but an interesting finding in itself. Just for those of you who are interested in some of the stats, I won't spend a lot of time on this, but essentially this is what's called a scree plot, and it plots these 5, 6, 7 different dimensions. But what you see there is that the strongest dimension, the EI, which is the emotional one, is the one that most differentiated between the different people who completed this form, followed by the one about warm support. Also, in terms of reliability, and again, I won't spend loads of time on this, but just to say that whereas the reliability on the previous scales, which is how much all the items within a scale are kind of correlating together, on our previous version, it varied between about 0.5 and 0.7, and that's really gone up this time between 0.8. And we developed the measure using samples from China, the Czech, which Zhuang Shay was involved in, the Czech Republic with Thomas, as well as the UK and the US, so that we could make sure that it was more culturally reflective this time around as well. Just the other bit of the form then is kind of personal preferences. There's some open-ended preferences, like do you want a therapist of a particular gender or race? And we've normed it so that we've just got the 4 countries at the moment, and actually only UK is on the website. But now what you can do is basically when you enter your details, and what the website does is it says relative to other people in your context, you have strong preferences here, strong preferences in this way, or no strong preferences. So it's something that the idea is therapists could either give their clients a hard copy of the form, they could do it before the sessions or do it together. Or what the therapist could do to clients is say, well, you might want to go to this site and you might want to complete this measure as a way of thinking about your preferences, and then you can either send it to me or just bring it in and we can talk about it. As John was saying, it's completely free. We've been very lucky to have some funding from John's University and also the University of Roehampton to set up the site. The only exception to that is if the commercial organisations are using it, there's a small fee that will go towards developing the measures, and also anything coming from today we'll be using that to develop the site and the measures. So if you want to get the recording, for instance, money towards that will go towards the site. What we find is that we've done qualitative research, and we find that clients seem to generally like the measure. I mean, again, there's a real variety. Not all clients love it. Some think it's slightly strange. But at the other end, we've had clients say, wow, that is, as John was saying, well, that's the first time that anybody's ever really asked me about what I want. And that for clients can be a really empowering experience. And I think, as John was saying about those different mechanisms, that a tool like this is not just about matching the preference per se. It's also about showing and communicating to clients that we're interested in, that we value what they think, and that the alliance is important. The first version, and we need to get it up there actually, but there's a number of translations of the first version. And it can be done, as I was saying, online or in hard copy. So what I wanted to invite you to do, actually, if we can just put that link, that Talking Preferences link, in the chat, and I'll just put that in there. So it's talkingpreferences.org. And what I wanted to do is just give people like 5 minutes or so, just to complete the measure for themselves. And either you can do it, so if you go to the site, and if I could just share that to you. So if you go to the site, you can then go, and if you go to the adult questionnaire, if you're an adult, if you're a young person, you might want to do the young person's one. Just click on start the questionnaire and just take a couple of minutes to have a go and see what you find out about your preferences. So let's do if we just take 5 minutes until past, just to try it out and see what you make of it. So I've just seen somebody say they can't get to the site. If you go to the resources, but if you do the HTML form that Brett did, it will score it for you, which is very, very cool. I don't know. Can we put the link to the resources in the
Just
chat?
looking for the HTML. Oh, we've got the resources folder, Mick, I think. Yeah. There it is. Thank you, Sebastian. Great.
Thanks. Yeah, sorry, actually it's not there, is it? Let's just go to resources. Sorry, this is the first run of it. It's on the website, the HTML. I'll put in the chat. So you can use that HTML directly with clients, and as you do it, when you score it, if you don't want to use the website, that's the other way of doing it, and then you get your results, which is very, very, very cool. I don't know.
Mick, my experience of printing this out reminded me of the joy the first time I got a personal printer and I pushed a button on my computer and I ran next door and there it was. It's magical.
It is.
For those of us who've been working on it, it's magical. For the rest of you, it's like, yeah, it's kind of
Yeah.
cool.
Yeah. Where's Brett? I don't know if Brett's here, but he's an absolute genius at this. Yeah, do have a look at the HTML. And yeah, as we were saying, these are all free to use, these tools. So not free to adapt, that's the only thing. Free to use, free to distribute, but please don't adapt just because they need to stay consistent for kind of research purposes. But if you're interested in translating or like as Charlotte was saying about the resources, there's different things. Like Thomas has developed a therapist version that we've then done research on, and there's lots we need to do more, like a supervision version. That's just in very early stages, but we've got a methodology now, and at some point we'll be writing that up. I don't know if anyone, if we want to take a little pause to see if there's any comments about the form or questions. I'm going to give you some examples. I'm going to show you a couple of videos of its use. One, John, I'm going to show you using it. And then I'm going to show my favorite video, which is John demonstrating how not to use it, which is very cool. Any questions, comments? How do people ask questions? Put their hand up.
Yeah, just click on the react button. Oh, Charlotte, I see you're unmuted. Yes.
Yeah, sorry, I was just going to say, Leah asked a question a little while ago about the supervision preference. And she writes, who developed the supervision measure?
That was done. We did that. That was a long time. What we did, that was about 10, 15 years or so ago, and really needs updating. If somebody had time, it'd be fantastic to have some version of this that was for supervision. Because when I met John at the APA in Washington in, I think about 2015, we had actually got an earlier version of this, but it was just a checklist. It was like single items, which is what the supervision one is. And John said, that's not that good. I showed it to him and he's like, you know, what you need is a proper measure, which is why we developed the CNET. Yeah, but Leah, if you want to email me, I can definitely talk to you more about that preference measure. Right, let's have a look at John then, demonstrating how to use the CNET. And let me know, I'm sharing sound, but let me know. And this is the videos that we've got that John was mentioning earlier.
Welcome back, Dave. And thanks so much for.
So sorry, just to say that if you were using this with a client, you would, this is in demonstrating in online therapy, but you would, in this example, you might email the client the form, ask them to complete it, and then send it back. And now, of course, this is with the earlier version. Now there's opportunities to do that directly.
Oh,
can you hear that? Okay.
Can you just put the sound up on the just right? Oh, perfect.
And thanks so much for completing this CNET preference form. um, after our first session. As you might remember, this form helps us individualize or personalize therapy to you to reach your goals. So I've had the time to score it. And on 3 of the scales, Dave, your scores are in the average range. So on directiveness and present past orientation, I'm delighted to see that you're flexible and balanced. There is one notable score that indicates you have a strong preference for our sessions involving lots of intensity, affect, emotions. Can you talk a bit about that?
Yeah, well, when I was filling that in, I was sort of thinking, I kind of like to get directly to the point with stuff. I'd prefer it if we could not talk our way around things. I felt like, I had counselling in the past and it seemed to go on, but I just want to get straight to the point with things and maybe tackle issues directly and specifically, if that makes sense.
That does make sense. And we'll try to honor that preference. And if I'm hearing you correctly, it's direct to the point, get to the feelings. And if I am a little too direct or hitting on a sensitive topic, a little too hard, do you think you would let me know?
Yeah, that would sound agreeable. Yeah, that's good.
Perfect. And if I'm not pushing enough, if we're not dealing with enough affect, feelings, you could let me know about that as well.
Yeah, for certain. I've had a tendency to bottle stuff up in the past, but it's I think we need to get it out. That's probably the best way to approach it.
Okay. Well, we'll certainly start that way and reevaluate as we go along then. So that's very helpful. And that's also the model for how we'd like to work together, Dave, that you're expressing your feelings about the session, about yourself, about me as we proceed. Fair enough?
Yeah, that sounds reasonable. Yep, good.
Good. And on the back page of the CNIP, you also indicated a desire for not only individual therapy, but couple therapy. Could you elaborate a bit on that?
Yeah, if I'm honest, I think maybe some of the other stuff that's been going on is being dragged through the household. We're just not getting on at the minute, if I'm really honest. There's a bit of tension. Even simple things like trying to decide what's being cooked for dinner. It's all out. The dirty laundry's everywhere. I think it would be good for both of us to get in the room and maybe thrash some of these things out sensibly.
Well, I appreciate your candor and your disclosing that. I do both individual psychotherapy and I also conduct conjoint couples therapy. So in a few sessions or when we think we're ready, we'll invite your partner in then.
That sounds good. Okay.
All right. So thanks again for expressing these preferences. It can really direct the therapy and make it more effective. So let's start out right along this path.
That sounds great. Okay.
Just to say a few things about that, and then John might want to comment as well. I think one is just to really note that the use of the CNIP is as a basis for dialogue. That it's not about saying, okay, there's a score 3 here, I've got to do this, there's a score here, I've got to do that. It's really about using it as a kind of stimulus to talking about what the client wants, understanding more. In all the videos, if you have a look at them, you'll see that all the preference work is about having a conversation and creating an alliance and a relationship and a space in which clients can feel that they're heard. And I think the other thing that I really like that John does there is that he's very affirming of the client's choices. So where the client's kind of not showing a strong preference, he's very positive about that. Where the client is showing a strong preference, he's positive about that. There's no kind of diagnosis or pathologization or, what's that about? And just the third thing is also that John was saying earlier about kind of working within his scope. And you can see there, John offers couples therapy. If it was myself, I don't do couples therapy. So it would be having a conversation about that. But I think we kind of work on the basis that if a client wants something that we're not able to offer, it's generally better to have that conversation up front rather than, it kind of turning up 6-7 weeks down the line or something. Certainly I've had the experience, and also as a supervisor, that sometimes you get you know, a number of weeks down the line, and actually you realize that what the client wants from the therapy is not something that you can offer. Like maybe, you know, you've been listening, you've been very empathic and working in very person-centered ways, I tend to do. And then, you know, a client will say something, you realize that the client's actually waiting for you to give them all the answers and tell them what to do. And I think we kind of work on the basis that it's better and fairer for clients as well to have that conversation up front. If you're not giving clients the answer, that's how you work, great. But to be transparent about that rather than have a kind of mismatch of assumptions. John, did you want to say anything about the video before I show you your example of what not to do?
Well said, Mick. I would just punctuate 2 points. I've never actually mentioned a numerical score to a patient. I just say what's average and what's high. And my second point is, instead of just saying it's average, I prefer to, it may be a reframe, but I honestly believe it, that if people are toward the middle, they are flexible, they're balanced, they're willing to move both ways. So I think we can describe those as flexible, balanced. And then I do have supervisees who sit and talk about numbers. They're just arbitrary metrics. Patients have no idea what a 16 means. So please just summarize and get on to the important clinical stuff. Don't get mired in whether it's a 15 or 16, right? That's not all that urgent, and certainly not worthy of your valuable clinical time.
I think one thing you've emphasized, John, is that often these conversations can be pretty brief. Like, you know, what are your strong preferences? Maybe the form, just picking up strong preferences. Overkill clearly is not particularly helpful. But it is also about taking it seriously. This is we did a video about how not to assess client preferences. And I think that, you know, one of the things people sometimes do with measures is to just kind of almost kind of throw them at clients and kind of not treat them seriously. And obviously, if we don't treat them seriously, then clients are not going to. Let me play you this.
Well, I don't know about you, but I hate these forms. But we need to complete them. So look, if you'll just complete them quickly, just scribble down some answers, then I can mail them in and we can do the real stuff called therapy.
Oh, good. Yeah, no, these forms are the worst.
Agreed.
Here.
Thanks.
John, would you like to comment on that?
You know, it's like Saturday Night Live, the UK edition from London. You're allowed to drop the F-bomb. We don't do that in the States. I guess I knew this was going to be for an English audience.
Where you want to get?
Sorry, John, say that again.
Get on with it, right?
John, sorry, say that again.
This is a bit like Saturday Night Live for the UK. In the United States, we can't drop the F-bomb, but I knew it was going to be a UK audience, so I could drop it here.
Thank you. We're honored. So I just wanted to give you an example of kind of working with it from my own practice. And sorry, I'll just turn off these subtitles. And I think just to illustrate kind of like how it evolved in the work with a client. So this was a client, and obviously it's disguised. And just to say, sorry, I should have said that in the video that was an actor, and we use actors in our videos just so that there's not issues of disclosure. This was a client I was working with who came with severe depression and had really struggled with anxiety and depression since their childhood. The father had really difficult mental health problems, and the mother too. There was a separation from the mother. They'd experienced bullying at school, and they talked about it in the first session about something traumatic in the past, but didn't really say much more about it. They were with a partner, but they weren't. They felt that there was a barrier between them and their partner. They were in a lot of pain, weren't sleeping. And didn't want to set any goals for therapy when I asked them about that, but did say about they wanted to explore past experiences and cycles of negative thinking. So, and just to say, this is the earlier version of the CNIT. So they indicated at the beginning that they wanted to, there was a strong preference for focusing on the past and also being more having more of a kind of focused challenge, which runs a little bit. I mean, going back to the point John was saying about authenticity, runs a bit against my grain. I tend to prefer kind of more warm, supportive way of working, but I can try and stretch towards being more challenging. And so with this client, that's what I was trying to do, be more challenging. They wanted more kind of therapist lead, so also being more leading, and we explored things about the early relationship. He talked about his mother being very neglectful and dropping out and difficulty showing his vulnerabilities. And I thought it was interesting. I felt very connected to him, and I thought the work was really going well. But then, you know, kind of unpacking it and trying to understand it and trying to support more self-acceptance. But actually, when he rated, I was also using some session rating scales, and they're interesting because often you see that your perceptions and clients' perceptions can be quite different. And when he did that in our review at session 4, he actually didn't seem to be getting much out of the work. And he talks about the way that he's very good at kind of giving the appearance of being in connection, but actually he's often quite disconnected. And he was very ambivalent still about the work. So we did the preference inventory again, and this time what he was saying is, again, more towards the kind of therapist leading, more towards the focus challenge. And even though I felt like I've been kind of pushing it, it was a good reminder to me that actually I needed to be a bit more kind of out there, a bit more sitting forward rather than sitting backwards and kind of prompting. So we talk about that, and I say, you know, this is verbatim, although, as I say, the details of the client's been disguised. So I say, you know, is there ways that I can be more helpful? I mean, I saw in one of the forms you were doing about wanting structure, I said, you know, does it feel too unstructured? And he says, yeah, slightly too unstructured. I kind of don't know what to talk about. So prompting is probably good. So we carry on, and we in this review session, and I do try and then really hear that thing about he wants more prompting, he wants more direction. You know, me just reflecting back is maybe not the most helpful thing for him. So I say to him, I mean, I did want to talk about some of those experiences that you said were more difficult to talk about. And he says, but I don't know where to begin. And I kind of stick at it, maybe a little bit more like working in a person-centered way. I might reflect that back. It sounds like you don't know where to begin, or I wonder how it feels to not know where to begin. But really listening to the client's direction, I kind of take that on board, and I invite him to say, you know, tell me something that's difficult maybe. And he says something that's difficult, and I say, yeah, something that's difficult to talk about. I mean, if you pushed yourself a bit to talk about something that's different. So it's almost as if he's kind of giving me consent to challenge him more. And we've seen in the research that often clients say that actually, although they know that they can find it a little bit uncomfortable being pushed, actually they want it. And coming from a person-centered standpoint, I don't feel totally comfortable sometimes like pushing a client. I don't want to push a client, but actually that's what they're wanting. And if there's a conversation where a client's saying, no, actually I do want you to push me, I do want you to push me out my comfort zone, then there's a kind of invitation and a consent for that. And then obviously it gets evaluated, and the client might say, actually that was too much. But you know, it's kind of clients sometimes recognize that what's good for them in the long term is not necessarily what in the short term they're going to react to. So I say to him, you know, if you push yourself a bit to talk about something that's difficult, and I says, you know, I can't, and I say it feels scary, and he says, yeah, it's just that there's things I don't like to admit to myself, and I haven't really admitted out loud to people and don't talk about at all. And again, you know, my inclination might have been to reflect that back and what's it like not to talk about things. But because this is a client who said to me through the preference forms that he wants to be pushed and prompted, I kind of push back a little bit and I say, well, you know, why don't we try and see how that goes? And what he does then is he does start talking, and he talks more about a kind of an experience that he had that was really difficult when he was younger. And it seems like it's quite a productive kind of conversation, and he opens out about that, and it's the first time that he's talked about that. And I'm kind of checking out as he's going, is he okay talking about this? Does this feel all right? And we've done some kind of grounding work as well so that he, you know, that kind of trauma-informed practice to begin with. And at the end, I'd kind of check this out, what John was talking about, kind of topping and tailing, like introducing these things and then also evaluating. And I say, I mean, I just want to ask, I mean, you've been really open, and I guess I've been pushing you a little bit more. Has that felt okay? And I says, yeah, I find it easy to talk, I think, with you pushing me. So he kind of reinforces that thing that he wants that pushing. And I say, you know, I guess it's important that you can say that you don't want to talk about things. And again, he says, you know, it just feels better when it's coaxed. And I think that if you look at the literature on broaching or questions, then for some clients, having that kind of invitation does feel helpful. And that's part of that kind of collaborative work that, although sometimes being quite non-directive in practice can feel like the most collaborative things to do, it isn't always. And if you've got a client saying, actually, I want you to lead, or I want to be challenged. You know, one of the things I will often ask clients about, as John was saying, is you know, have you been in therapy before? What's been helpful and what hasn't been helpful? And overwhelmingly, the most common answer is clients saying, I worked with this therapist and they were really nice, but they didn't push me enough. You know, that just comes up again and again and again. And you know, clients saying, I want somebody who's going to take me forward. I think about it a bit like kind of going to having a massage or something that, you know, it is sometimes more painful when somebody's going to really digging their fingers in, but it feels so much better at the end of it and it feels like something happens. And I think that's what clients are sometimes asking for us, sometimes, but not always. And that's why having some explicit conversation is helpful. So let's go on to the young person's form. The U-PIC, understanding preference, I don't know if Andrea is still with us. It was Andrea came up with that great title. And, you know, we know that in work with young people, although there's not that much research around preferences and accommodating preferences, there is more evidence around shared. There is actually quite a lot, and Charlotte's looked at this, around shared decision making with adolescents, showing that generally it's good. You know, these aren't things that kind of radically transform the outcomes, but as John was saying, with adults, where you've got small improvements building on other things that can help improve outcomes, it does become very meaningful. And we started off with a while back, a colleague of ours, Trisha, did a form called What I Want from Counselling Checklist, and that evolved into, thankfully, through funding from BACP, we got some money to develop that into a fully fledged young person's measure. So this is our understanding preferences in counselling form. It's a briefer form, and we appreciate that young people aren't going to want to spend as much time, but basically the same idea. And we've got 14 items on 4 subscales. 3 of the subscales then kind of link into the adult, similar to the adult ones, although the wording of the items is different and the scale is also a bit narrower. That's the one around therapist to lead. That's one about emotional intensity, and that's one about therapist challenge. But we also have what we found that when we talk to practitioners who work with young people, a big question for them was whether or not the young person wanted to use more creative materials and play materials and art materials. So that seemed an important item to also have on that. So maybe again, if you just want, I'll just stop sharing. And if you just want to take a couple of minutes just to go back to the Talking Preferences website, again, let's say 5 minutes, and then we'll go on to hear from Ellie about her kind of young people's involvement in the measure, which was such an important part of it. But if you go to our website and you have a look at the young person's questionnaire, just imagine as a young person, actually, you know, when you're younger, what you might have said there or how it might have been to be asked. Yeah, just take a couple of minutes to have a look at that. You'll see that it's similar and also a little bit different. And if you can't access it on there, there's also in the resources are the forms. We haven't got the HTML self-scoring one. Okay, I think just as people are doing that, I'll just carry on as we're rapidly running out of time. So I know that, you know, sometimes you look at these forms and you think somebody must have done that on the back of a fag packet, so to speak. But I just want to say a little bit about how we develop these forms, because it really is. This one, I think, took us about 2.5, 3 years. And just to kind of give you an idea of how they evolve. So this one went through 7 stages. And we didn't do all these stages on the adult one because we'd already developed it once, but just we're going to talk through a few of some of these stages, from kind of collaborative design with young people that Ellie's going to talk about, and then developing the items, rating the items, doing interviews on the items, and then doing some statistical analysis. And then the last stage, is Charlotte was mentioning, is going to be doing interviews to see how people actually experience the measure. Ellie, do you want, over to you? Shall I do the slides and then just tell me as and when you want me to move forward?
Yeah, that would be great. Thank you. So hello, I'm Alishka. I'm part of the Young People's Advisory Group at the McPin. And I'll just be talking about how I've been able to help with the project. So could you go to the next slide, please? So as you can see, there were many points over the last 2 years where the advisory group got to collaborate with Mick and the team. And I'll just talk through about what we roughly covered throughout the 2 years. So starting with in May 2024, which is literally 2 years ago now, we got sent a few questions to prepare answers to in advance of our meeting. And it was essentially getting us to pretend as if we were beginning therapy, and how would we essentially want a preference measure to be, and what would we really not want it to be like. It really felt quite vague at the start because it wasn't, the idea wasn't really developed, and we got told we were helping to develop a preference tool, so we weren't even sure what it would look like. So I think it's been interesting to see it kind of evolve and grow over the time. But we got asked how might young people vary, so give examples of differences we think that people would have in how they want their therapy to be. So I just thought of how I would want therapy to be, or how my friends that I know have talked about therapy and what they've told me about what they liked and didn't like about therapy. And then we also just generally discussed about how the project sounds, whether it's a good idea or whether we don't think it's pretty interesting. But yeah, so we had some answers where lots of people were saying they wouldn't even know that there would be preferences to therapy. They didn't know that there'd be different versions of therapy that would be available to them. So and there was also an emphasis on people saying the preference tool would be viewed as a start of the relationship with the therapist. So those were just like initial ideas that we were thinking about. And also key things to point out was that lots of people were saying we wouldn't want it to be too long, and feeding back that we wanted less free text answers, so we would want to select options rather than input our own words specifically, because someone said, and this is a quote, if your needs have never been catered for, how will you know what they are? And I think that's really kind of important feedback from young people, and it really gives you insight about how important a preference form can be. So then another meeting we had, I wasn't part of the December steering group, but so I can't really feedback on that. But another meeting that I was a part of was the January meeting, and we were just talking about how there was a poster to advertise for the interviews that would test the measure. And we were talking about how clear it is visually, and what it could, what changes could be made to make it more visually attractive to young people. So we were emphasizing the idea that if you put the kind of target or the goal of the U-PIC project, at the time it wasn't called U-PIC, but if you emphasize how the interviews can really help young people in the future, more young people would want to take part in the interviews because they would really see that they're making a difference. And then we were also asked, how would we like to do a questionnaire if a researcher came and did it with us in school, and kind of what would make us the most comfortable to do it in class, and kind of what that layout would look like, whether we'd be scared if other children would see like our answers, and just how that could work if a researcher came and presented the form in school. And then we were asked about the interview process itself and whether that's the instructions for that were understandable or clear, and how it could be changed to make it more clear. And we discussed that maybe instead of an information sheet of just writing which describes what you do in the interview, there could be a video which explains the interview and the importance of the interview. And I actually got to be involved in that later down the line, and I got to make the video for that, which is very cool. And we also emphasized that we wanted the video to be saying the main ideas that the preference form is meant to be empowering for young people. And we also wanted to say that the researchers should push the narrative that it's really handing back power to young people when they complete the preference form. So it was good to get these kind of aims in line in that kind of meeting, if that makes sense. But yeah, then in April, there was an opportunity to be a part of a lived experience panel and talk about mental health and what good mental health environment would look like in schools. I didn't get to be a part of that, but it was a thing that the Young People's Advisory Group got to participate in. And then we also, again, in April, filled out the form ourselves and discussed how that felt and whether we think that the layout was okay. And there was just a lot of kind of adjustments that we made along the way. And in this point in time is where we voted on the name. And it's interesting, and I'll show the examples later, but it's cool because we were able to see kind of the development because it wasn't always U-PIC, as I said. So we also talked about how the U-PIC form could be used, and lots of people brought up the fact that we would feel quite uncomfortable filling in a form right in front of the therapist, and we were saying it would be great if the form could be given to complete in our own time. And we were also saying that an online version would be really good and accessible, especially to young people. So it's very nice that it's available on the website as well as in person on a physical paper copy. And then there was a steering group that was held, and I think that was a summary of kind of the evolution of the project to that point. And then in September, we got updates. So even though we weren't involved at that point, we still got updates from Mick, which was really actually nice, because often you might join a project and you won't hear for a long time about how things are going, but it was really nice that Mick and the team kept us updated and sent us like where in their research they're at. And then January this year, we also talked about the website and the appearance of it. And I think there was a point made that the website could use photos rather than drawings, because photos of other people would make younger people feel more connected, and it would be more personal than drawings seen on a website. So I think it's really just little adjustments as well, and I think that's cool because everything kind of adds up and makes a difference. And then most recently, there's been dissemination tasks, and I got to be involved in one of those. So in April, I got to join the Society for Psychotherapy Research Methods Conference, which was held in King's College London. And we were able to talk about preferences, the use of preferences in therapy and what's good about it and what's not good about it. So I was able to use lived experience to input on why I think the U-PIC form is actually really beneficial in therapy. And could we go to the next slide, please? And here are the examples that I was talking about of our input. So at some point over the 2 years, we had this opportunity to brainstorm keywords that we think would be useful to include in the name. And we had dynamic at some point. because we wanted to emphasize that preferences can change, but we didn't end up using that. But I just think it's interesting because you can see that there's an evolution to the name. But yeah, we used a Mentimeter to rate our preference of the name of the preference form. So with 1 being that we didn't like it much, and then 3 being that we really liked it, and then U-PIC ended up winning. Can we go to the next slide, please? And then I just want to talk about what I enjoyed the most. So to me, the most important thing was that I was able to be included in a meaningful and impactful project, because therapy, I think, is a really demanding thing, and it demands courage, and it demands commitment, and also trust in a stranger who you're telling really, really personal things to. So I think it resonated with me that young people should be asked their preferences. So I really enjoyed that part of it's an important thing that I believe in. And then also the entire project, it felt like there is a end goal, and it's a tangible kind of thing, because we were told that hopefully it will be used in schools and maybe hospitals, or just any therapy area, and it felt really real and really widespread. So that was very rewarding. And then the second aspect that I really enjoyed was being able to use my personal experience. And this is what MCPIN is all about, being able to use your own knowledge or opinions and thoughts about things and that are relevant, and feed back into research. So I had an experience where I was helping a friend to get help through counselling, and working on this project was really really nice, because I was able to see how this project that I'm actually involved in can help people who are like her, and I can see how my input was shaping this and how it could make a difference in the future as well. Next slide, please. So I just think it would be nice to include feedback from other people in the Young Persons Advisory Group who aren't speaking here today, but this is what many people said that they enjoyed. So as you can see, people are talking about appreciating that there's opinions from other people, other young people, so the genuine value and input of contributions from others, and then good working relationships. Someone put that it's nice to have that collaborative atmosphere, and then how well that worked in terms of moving the project along. And then someone talked about I've enjoyed being able to see all the different iterations of the form and how YPAG input has been taken into account. Yeah, I really agree with that, because we could see the project evolve from just being a tool to being a preference form with a name as well. And I think it's really satisfying to see how your input over a long period of time, over 2 years, is being represented and acted on. So you're being listened to, and it's not just that it's not just that Mick was ticking a box of participation of young people. It was literally collaboration. So that was really nice. And then learning elements of graphic design and working on designing the form. Yeah, this was also surprising, because we had to consider how like colors or text and font size could be seen by young people, and how to make advertising more interesting. So yeah, I agree with that as well. And then working with a team of therapists and researchers who are receptive and idea sharing and feeling valued. Again, there's like a common theme of having this opportunity and really it being acted on, like what you input. And then working on something that will help other young people, with the output being clear, and we know exactly what would come out of the project and how it would be of use, is, as I said as well. Yeah. And then I enjoyed helping to shape the form and having our opinions heard. Yeah, so a common theme of being heard. Yeah, and that's it. That's what I see.
That's lovely. Thank you so much, Ellie. And you know, it was great to have your input. And I think it was, you know, that collaboration was such a core part. And I guess you talking about that helps people think about, you know, when we do research like this, just how important and how valuable it is to have the voice of participants, young people and people with experience
Yeah.
to feed in that process. So, and there might be some comment. I'm just going to take like the last 5 minutes to talk a little bit more about the process of developing the measure. And then we will go on to just for Q&A. So once we'd had, like Ellie was talking about her, the kind of involvement over the process and particularly kicking it off, but then we went around, we then generated items for these dimensions. And one of the main things, we looked at the literature, but one of the other things we did is we interviewed, I think, around 20 therapists. And the key question was, as I was saying before, it wasn't, you know, what is good practice? And it was quite a tough question, actually. It was the question of like, what are the things that you're willing to vary with your clients, where it'd be really good to hear what your clients want. So that was where people were saying things like, oh, you know, like with artistic material, I know some young people like it, some people don't. And we've developed that question we're using, for instance, at one of our students, Sally, who we mentioned earlier, is doing something where she's developing a waitlist preference measure. And it's the same thing that she's talking to managers of wait lists and saying to them, like, when somebody's on a wait list, what are the things that you might vary, like the amount of contact where you think both things could be helpful, but it'd be good to know what people want. So we did that, and we used kind of the previous measure as well to identify some some dimensions, like whether people want goals or not, creativity or not. And then we kind of like finalize the item pool, develop these dimensions that we thought seemed relevant. Like there was ones around use of silence that we thought might be useful, but in the end, that one didn't stay in on it. And then what we did is, so we ended up with about 60 items. And then we went through a process of rating all the items where we got people to, about 20 people, to say how much they thought this list of 60 items, were they well formulated, were they well suited overall? And then again, we took out some items because they had double meanings or they weren't very clear. What we did next, and Andrew is going to be doing a presentation on this at the BACP Research Conference, is that we did something called a 3-step test interview, where basically we asked young people to do the form, these items, and to speak aloud as they were doing that, so that we could see again what was making sense, what wasn't making sense. And again, that led us to take out some items that people were saying were too vague or confusing, or when they actually did it, although people have rated it as okay when young people were doing it, they didn't make much sense. So we took out about another 15 items. And then we went through a process of getting a survey done across about over 400 young people, where I think this is called a scree plot again, and that's where you kind of identify the dimensions. And as you can see there, the main dimension was this one about emotional intensity, and then one about creative activities, then about challenge, and then about leading. Those were the 4 dimensions that came out. Again, with good enough reliability. And then that's led, and now we're just going through this stage of confirmatory factor analysis, which Brett sent me the results of just about an hour ago. I don't know if Brett's here, but yeah, it's not looking too bad, which is good to see. And then what we've got is at the end is Charlotte's going to be doing interviews with young people actually using the form in clinical practice. So I hope you get a sense there that, you know, with these measures, and obviously it's not going to be kind of completely right. And with the adult one, we kind of, well, really, this is our 3rd iteration, because we did the first one, which was a checklist, and then the second one, and then now we've improved it. So it's kind of ongoing, but we hope that the measures are kind of moving in the right direction, and hopefully eventually they will get more and more useful. So John, we've got 15 minutes. I love that. John.
John is here to
John
to facilitate, share some questions. So yes.
So I think we've got questions. So we got Eliska, and we got John, and we've got Charlotte's here. And who we got?
And I can see Brett as well.
Brett's here. We're able to highlight maybe everybody who's part of the team. We've got Emma. We've got
Let's do that with the spotlight, Sebastian. Thank you.
So who else have we got here? We've got Leah, actually, who's a member of our steering group.
Let's bring Leah on
everybody,
as well.
everybody in the team is suddenly getting nervous. Thinking, I didn't realise.
What questions are we going to be asked?
What questions? Brett, let's get Brett on camera if we can, because if anybody asks anything complex about stats, that's going to have to go to Brett.
We don't see your camera yet, Brett, but if you are able to turn on, we'll spotlight you, and if not, we understand too. So, good. In terms of questions, if anybody wants to just click the react button and raise your Zoom hand, we'll see you and be able to unmute you.
I see the main.
We can see you. Great.
Okay, where's Brett? Is Brett brilliant? I can see the main conversation in the chat is about whether it's possible to access John's video where he's swearing. It's like the hot issue. Oh, it should be there.
This is what we want to know. Can we watch it? But it's there, isn't it? It's on there.
Have we got anybody else here? Andrea.
Have we missed anyone?
Have we got all the team? We got Andrea?
I'm here, everyone. I thought I was going to get away with being spotlighted then.
And Leah as well.
Leah, let's spotlight Leah.
Yeah, Leah.
Good to see you too. Are we spotlighting people?
Yeah, if you go onto your speaker view, Mick, you should be able to see that.
Oh, brilliant.
And if we have anyone else, you can drop me off, Sebastian, off the spotlight. And I think we can also unlock the mic. So if anyone just wants to...
We got Emma. Emma's evaded it so far. We got Emma and Eva.
Emma, let's see.
They want spotlighting.
You could just drop me off, Sebastian. Still be able to hear me, but yeah.
We're going to spotlight everyone and then we won't have any questions.
It's just so nice to see everyone who's been in the project.
It's a big team.
Yes, it's great.
Well, Mick, while we're asking for questions, I'll throw a commercial out there. An advertisement. If someone's looking for a master's thesis or a topic for a doctoral dissertation, Mick and I are particularly interested in someone taking the reins on the supervision preferences. It just needs some dedicated work like a thesis or a dissertation. So just throwing that out there, friends.
Absolutely. That'd be fantastic if somebody wanted to do that. Oh, you disappeared, John. Is Eva? Where's Eva? She disappeared. Thanks, John. John, where's John? We lost him now. We don't know if there's any questions.
We're not. Oh, there's a question in the chat. What happens to all the information inputted onto the website? So I guess that's a kind of data question, isn't it? And yeah.
So we give people the option about whether they're okay with us keeping the data, and if they are okay for us keeping the data, it will be anonymized. It's all anonymous, and it will allow us to update the norms and also to use it to kind of improve and refine the measure. So, but it will all be anonymized.
Thank you, Mick. That's great. And then we've got another question. Might you provide a reference to the text that describes these 7 stages in detail? And I think that was the 7 stages of kind of developing the measure, I think. Hi, Eva, we've got you now. Hello.
That's going to be coming up. We're writing up the paper at the moment. So that will be on its way. Oh, what's Brett? Do you want to answer that one?
Yeah, I've just dropped a reference into the chat that's one of the kind of main papers that we've been drawing on in informing those 7 scales. So it will give you something to read in the meantime while we're writing up.
Thanks, Brett.
Thank you, Brett. Great. Anything else? Let's see. Either in the chat or anybody wants to click that unmute button and ask a question.
Was there anybody in the team who wanted to add anything else while people are thinking about questions or any comments? Sorry, it's been mostly me. John's gone. Is John gone?
Because we can only have 9 on the spotlight, so we just swapped you out, John, for a moment. Hopefully that's okay.
You can take me out, put John in, he's more important. So anybody else in the
Could I just say something really? It's Leah, Mick, that's speaking.
Hey, Leah.
Hi, everybody. Lovely to be here. I guess I just want to say that it's been fantastic being on the study steering group, but to also say from a neurodivergent perspective, it's something that I'm really, really passionate about. And I guess one of the things that I'm thrilled about this measure is it feels really, really inclusive. As someone who is dyslexic and has APD, I think for me, it's really, really strengthened that notion of personalisation within sessions. And I can't wait to operationalise that much more with some of the young people and children and adults that we work with. So yeah, well done team. I think it's a fantastic resource. Can't wait to see how it rolls out.
Thanks, Leah. It was great to have your input and the support of somebody who's really out there in practice, aren't you, and doing the work.
Yeah, very much in private practice, Mick, but working in lots of schools and various organisations in the community. So yeah, some of which are voluntary and charitably based. So it's great that they can get access to some of this stuff too.
Thanks, Leah.
Thank you, Leah. And I can see a couple of questions in the chat around completing preferences throughout the work, or maybe starting them once the work has started. And is there a way to record that as well?
Say that again, John. Sorry, I missed that.
So, like, do the preferences have to be completed at the start? So if we're already working with someone, we're here today and we think this could be ideal, would it be appropriate, maybe halfway through? Is there a way of thinking about doing it throughout the work as well, maybe at the start and throughout? And are there any ways to record those preferences? Sorry, that's about 3 questions.
Anybody want to have a go at answering that? I don't know, Thomas or Charlotte. Charlotte.
Yeah, I'd love to answer the one about whether you just bring it into the start or not. So, as I briefly mentioned before, I've been doing some interviews with young people who've been trying the U-PIC. And 2 participants, they've had therapy for ages, they've had a really good relationship with their therapist. Yet, I think these items, and in answering these items, really does bring out the processes. I mentioned before, for example, the item whether the therapist should accept the client or whether they want the therapist to challenge them. So the young people think and they look at it, even though they understand that the therapeutic processes, they think, okay, so how am I with being challenged? When have I been challenged in therapy? What about feeling accepted? I know that that's a really important part of therapy. So yes, I think it's integral to all of the duration of therapy. I think it's really good to go back. I'm going to try it again I think after 6 weeks of trying it the first time in therapy. We're going to go back and try it again in 6 weeks' time. So yeah, I think in any point in therapy duration, it's really useful. And it really seems to be bringing out those processes and putting them on the table. So whereas before, perhaps you would, as a therapist, you would work your therapeutic stance or skill or modality. And then by using one of these measures, it puts it on the table. And I've done the same with CNIT too as well, actually. And it does the same process. It enables something to be spoken about, put on the table, whether or not you've explicitly done that before. I think personally it's really useful.
Thank you, Charlotte. So the single American would have a comment on the first and the third then, to bookend what Charlotte just said. There are many colleagues over here who do not administer the CNIP until after 3 or 4 sessions of psychotherapy. They believe that then creates a baseline against which their patients can express. So that is done routinely as well. And when someone said, well, do you record? Well, if you are having print materials, I recommend that you just print out the results with the dates and throw them in your file, and you can look at it over time. Or just save it on your computer if you're not using paper files. That's it.
Thank you, John. Thank you. I've got another question in the chat that we could ask, if that's all right. I could just read that out. So thank you for this one. On the between session work, no between session work scale, can you please differentiate the options? Give me tasks to complete between sessions and give me homework to do. They're quite the same. In CBT, we actually have started to call the homework as an action plan. would you like to rename it as well? Would you like to go back into the 7-stage process? I can see you chuckling, Mick. What are you thinking?
Yeah, just what I need as we go into the weekend. Yeah, there's a few points there, and really, really good points. One is about similarities between items. So when you do measure development and when you're developing scales, one of the things is that you want your items to correlate, and it's really important that they kind of pick up a similar underlying dimension, but at the same time, you do want them to differentiate and to be saying different things. And sometimes what you end up with through this kind of statistical analysis is items that are quite similar, but they're kind of different bites at a cherry. And you're trying to look at things in slightly different ways, which is why sometimes they're a bit more similar than you would like them to be. We had I mean, it was one of our longest discussions actually about what we refer to as homework, and I think we talked about between session work. I think we were aware that in CB we were originally going to call it homework, but then we kind of got the sense that that's not so popular, that term. But action plan's nice as well. The problem is, as John was joking about, but it is true, like to change the wording, if you thought, right, we'll just change the wording on this, you have to go through this whole process of kind of validating it, which makes these things really slow sometimes to change. So, that's for like the next iteration, maybe in 7 years or whenever somebody's going to pick it up. But I don't think it's going to be me. I don't know if Thomas or John or anybody else would like to comment on that one. Thomas.
Well, not only does the wording need to be almost identical, we also sought to be integrative or trans-theoretical and certainly international in the language. So we purposely avoided only CBT or DBT or psychodynamic verbiage, trying to appeal to the grand diversity of theoretical orientations. So the wording must be similar to have a reliable scale, but broad and inclusive enough to appeal to all the people doing the work.
And to give actually useful information as well, we wanted to have as few items as possible, giving the most useful information. So, there's so many considerations statistically when you're choosing what are the best items, and you never get it quite right. Poor old Brett's been kind of mediating the whole process for us and doing a fantastic job.
And I just want to say for colleagues who need the CE credits, just to send me a little message as we wrap up in a couple of minutes to confirm the time you're logging out for Tracy, who's going to take care of us with the CE credits. So just do that, and then we'll have that also. We've just got a minute or two left, so we're coming to an end. I don't know, John, Mick, you might have some kind of final thoughts as we're kind of wrapping up.
Maybe one more question before that is that there's an interesting question here, so we won't get to all the questions, but do you have an opinion on evidence for whether the answering of the scale is more reliable when done before or within a session? I'm wondering whether clients are likely to reflect and answer more authentically prior to a session, although I appreciate working through it in a session could feel more dialogic, collaborative. Eliska, with the young people were saying that they would rather do it before, weren't they? That was quite a strong thing that I was surprised by, but they didn't really want to do it with a therapist there. Did you want to say a bit more about that? If you just come off mute.
So with us, when we got asked how we would like to complete the form, none of us really could want to do it in the session, because it just seems like there's sort of time pressure, because it seems like the other person's waiting on you to do it, and then you might not fill it out to the best of your ability. And then number two, it feels like if you might not be as candid as you would, because you feel like they're gonna see what you're ticking and they might judge you for that or something. At least that's what we were thinking. So we were thinking if we're given time to do it outside, it's just more free. You can think about it whenever you want. And yeah, but I guess you could be given a choice if you want to do it there or if you'd rather do it before.
Yeah, thanks. I think the online version now allows it to be done more easily before the session. So that was really, really useful input. I don't know, John or others have got thoughts on that one about when it's best to do the form.
Well, we had no direct research addressing this, and at the risk of sending us down an endless hallway of preferences, I really do think, as was just said, I just ask my patients, what's the best way to do it? Some people want to do it in session directly. Some people want to reflect and do it at home. So I ask, what works best for you? And I follow that.
Thanks, John. Thanks, John. So I think we're just coming up to time. Is there any kind of final words, John?
We had those final slides, Mick.
Oh, to me.
The two conclusions.
Conclusions, John. Quick conclusions, and then we will bring everything to a close. Do you want to go through them?
Sure. Mick, the team, and I, through this laborious process, conclude time and time again that this is fairly complex work and nuanced. At the same time, it aligns with evidence-based practices, it advances professional ethics, and it modestly improves treatment outcome and powerfully reduces dropouts and enhances alliance. So honestly, what's not to like? There are no simple answers to be true, which is just characteristic of psychotherapy. But working with shared decision-making in general and patient preferences in particular are likely to become even increasingly more important with the development of user-informed perspectives. So we're pleased to present with the entire team these robust, reliable, free measures for both adults and the youth, now available for UK and US populations. And if you just give us a couple more months, they'll be translated with probably norms for several other new countries. Mick mentioned it's been translated into 12 languages now. And that wonderful new website provides additional translations, norms, videos, and resources. Enjoy, friends.
Brilliant. Thank you, John. And thank you, everybody who's been here. And John and Sandra and Sebastian for hosting us. And yeah, do explore the website. And I hope there's lots of things that you will find useful. John, are you there?
I am. I'm just over here. Just want to say congratulations to the whole team. What an incredible project. And thank you so much for being here at Online Events so we can celebrate your launch and we can do some training around the website as well. And I'm sure it's going to have an incredible, helpful life in the world of therapy. So thank you, everyone. Thank you for everybody who has been with us as well to share in the launch and training. It's been great to have you, whether you've been here live with us on Zoom or you've watched us from the future. Great to have had you here as well. Wonderful. Last thing we usually do is open up the microphones. If anybody would like to say goodbye on the way out, you're really welcome to, and hope to see you again soon. Thanks, everybody. It's been great to have you here.
Bye, everyone. Thank you for joining us.